Okay. So, welcome to Chapter 8. In this chapter, we're going to be talking about health disparities. And the chapter actually covers health disparities, social determinants of health, and health literacy, all of which are incredibly important topics for health educators. So, the objectives are to list some populations that might require a health educator to present materials differently for a presentation. This is very important, particularly when it comes to health literacy, and to describe the demographic factors that are contributing to health disparities. Then also to describe the ethnic and racial disparities in selected areas of health, and the extent of research related to health and minority populations. So by the end of this, you're going to be able to justify the need for health literacy in minority populations. And I would say the chapter emphasizes health literacy in minority populations, but I would say health literacy for everyone, because if a person isn't able to get the information that a health educator is trying to disseminate, then your information was really for nothing. So I think particularly in the area of health education, health literacy is key. We'll also talk about the concerns and difficulties in studying minority health, and a little bit about the legacy of suspicion and concern amongst ethnic and minorities in the wake of the Tuskegee study. I should say in the video we're probably not going to cover that a lot, but it is in your chapter. So why study health disparities? Well, the reason is that while race is not a significantly valid biological concept, health discrepancies do exist by race, and racial and even ethnic identification alone doesn't convey the complexity in any particular person, right? So we're more than just our racial and ethnic identity. But studying disparities within group differences, we're studying health disparity highlights within group differences as well as between group differences, and then looking at the contributing factors leading to disparities. So this is a chart that's in your book, but you can see race is over here, but then the columns in here are quite diverse. So race and ethnicity might be one component, but then we also have biological factors, cultural factors, social network, racism, political considerations, as well as historical and legal. So just to say something briefly about each of those. So biological, so it might be that by race I'm not at risk for a particular disease, but it could be that my genetic history within my own family makes me at risk. Culturally, so while there's not going to be a biological disposition based on culture, there could be any number of things that culture pertains to that might put a person at risk, including simple things like food and culture around going to doctors versus traditional healers. That can be an interesting and complex topic. And then our social networks. So certainly within some cultures, there's a lot more social support than there is in others. Some of you may have heard of like when Latinos come to the United States, there's the Latino paradox. So while folks may not have as high of an income, they do sometimes very well in some instances with regard to their health, and that's presumed to be because of the social network and the social support, hence the paradox. Racism, so while we're not going to get into a lot of discussion in the course of this chapter on racism, racism has been definitely linked to show increases in cortisol, which is a stress hormone, and then cortisol can lead to increases in certain diseases and conditions. Political considerations, so certainly, so while this is being recorded right now, right before the 2016 presidential election, and just even the political conversations about healthcare, let alone all kinds of other matters. Historical, so the Tuskegee experiment, for those of you who may not be familiar, was an experiment that was done with African American men with regard to syphilis, and it really created a lot of distrust because information was withheld from subject matters, and then also legal considerations as well. And then this can affect then psychological stress, environmental stress, psychosocial resources and medical care, and then when you look at biological predispositions, and then health outcomes. So there's a lot that goes into health disparities. Healthy People 2020 defines a health disparity as a particular type of health difference that is closely linked with social, economic, and or environmental disadvantage. And health disparities adversely affect groups of people. And Healthy People 2020 defines health equity as an equal level of health for all people. And achieving health equity requires valuing everyone equally, with focus and ongoing efforts to address avoidable inequalities, whether those are historical or contemporary injustices. And there's a direct goal to eliminate those health and healthcare differences. So social determinants of health are those conditions in the environment which affect how people live, learn, work, play, worship, and affect a whole variety of health and health promoting opportunities for individuals. And an overarching goal in Healthy People 2020 is to create social and physical environments that promote good health for all. I should say in the division where I work at the healthcare agency, creating those environments is super important for us. And one quick example of how we're doing this. So we've gone into 3 different churches where there's higher rates of crime in the neighborhoods, not in the churches, but higher rates of crime in the neighborhoods that surround those churches. They also have, they don't have any parks or safe places for kids to play, and higher rates of childhood obesity. So we've gone into 3 different churches. We've talked to the parishioners and the residents who live nearby there, the neighbors, to find out what would get them to come out of their houses and go out and have safe places to play. So we understood what their barriers were, what they were looking for, and then we worked with the churches to open up the fields. And so like in one church they have Friday field days, in another church they now have Zumba and walking groups to change that physical environment that promotes good health for all, but also to create a social dynamic where the social norm suggests that people should be out and they should be active and they should be playing and they shouldn't be afraid, and together they have one another to keep each other safe. In terms of social determinants of health, I wanted to show you a model that was put together by some colleagues of mine up in Northern California. So this was developed by the Bay Area Regional Health Inequities Initiative, and this is their model in terms of addressing health inequities. So same thing, you hear there's the social inequities, then there's also institutional power. So those individuals who might be least influential to elected officials or to decision making, don't have as much power. Again, living conditions. So living conditions can include parks, like I just referenced, but it can also include like alcohol density. Overcrowding in housing could expose people to higher levels of mold, which can affect asthma rates. So then you can have increased risk of disease and injury and ultimately inequality. And so this is a model that's kind of good to look at as well. So moving on from social determinants of health to health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. So it's not just being able to locate and read health information, it's the ability to apply that information in order to improve the quality of life. Estimates indicate that approximately 9 out of 10 adults lack proficient health literacy skills. Let me tell you how this plays out in real life. So it could be anything from somebody gets their prescription medication and they're not able to read the label that's on their medication, so they don't take their medications appropriately. As I've shared previously, I've worked in HIV services. I've had clients in the past who weren't able to read or to write, and so the doctor would give the information to their children and tell their children, make sure that your mom and dad take the medicine properly. And some of these stories would be really tragic because they would tell the kids, like, make sure your mom takes this medicine right or your mom's going to die. And as you can imagine, for like a little kid, that's horrible to have to hear, and it's horrible to have to be responsible for that. So the emphasis on health literacy is really making sure that whatever it is that we have to say as health educators, that we're saying it in a way that can be that could be understood and used by everyone who we're trying to serve. And so this is a figure that's in your book, figure 8.5, and here's the medicine bottle. So it shows why it's important to follow directions. And so developing health literacy has been one of the skill sets has been identified to reduce health disparities. And so people need to have strong reading, listening, and analytical skills, as well as the ability to adapt them to a health situation. And developing decision-making skills allows the consumer to be able to compare and contrast. So it's not just about following directions, but also understanding the choices that's being given to an individual. So, it might be that a person has to, maybe make a decision between, surgery or other kinds of options, or there might be a couple of different medications. For example, if a woman is considering contraceptive care, there's all kinds of different birth control methods, so she needs to be able to make an informed decision about what method is going to be the most appropriate method for her. And so here's a figure that I just want to draw your attention to in your book. It's table 8.2. There's some great questions or some things to reflect on here, such as identifying who your intended users based on epidemiology. So this reflects back to your needs assessment or assignment 1. Making sure that the messages reflect the age, social, and cultural diversity, language, and literacy skills of the intended users. Again, part of your needs assessment. So for your needs assessment, you mostly looked at articles and looked at like statistics and data. But for your formative research, you might want to find out some of these other aspects as well, so that way as you're developing or choosing your materials, you do so wisely. So you want to really consider the communication capacities for the people who are going to be receiving your health education intervention. And understand this before you design your materials. So you could do like an initial focus group, kind of get a good sense of things, and then afterwards develop like a little draft of your materials and then go back and pilot again. I would really encourage you to make sure that that you don't make assumptions. So for example, if you're talking to an audience that's primarily Latino, don't assume that they don't speak English. By the same token, don't assume that they can read Spanish. I had a colleague of mine who is bilingual, bicultural. She was going out to do her presentation. She was really excited because she had everything like perfectly translated into Spanish. And it turned out that the people in her audience weren't able to read, so they don't read English or Spanish. I was in one audience where there was a woman who somebody came up to her and said, and this woman happened to have a PhD, but they stereotyped her as not being able to speak English based on her appearance. And so then when she responded, the person that was in the class said, "Oh, you speak very good English." And she's like, "Yes, I have a PhD. You speak good English as well." So just don't assume that you know what's up just based on appearances. You really want to find out. And when you're developing your materials, make sure that you have good cultural representation in your materials. I've seen more and more materials where people are using like icons and stuff instead of actually pictures of people, because that way they can sometimes be a little bit more inclusive by actually not representing anybody. If like the individual's purple, nobody's purple. So that sometimes helps. And just be also careful that things don't look cheesy. Like sometimes people use graphics where it's like, you know, is so diverse that really it looks like people stretch too far to have good representation. Make sure that you have not only representation of individuals, but some other things to consider. Like, for example, in one of my programs, they reach out to women who are of Pacific Islander descent, and so they had actual women who were taking the classes with their permission, and put them in the PowerPoint and in the materials. And then the health educator did interviews with them to find out like what kinds of patterns, like for example, in one case, basket weave was really important. So they used basket weave frames on the PowerPoint. So just make sure that you're really digging in, and because when people feel like something is designed just for them, they're going to definitely be more responsive. And so that's in terms of materials. And then when you're actually speaking, also take into consideration other kinds of cultural aspects. For example, how you're dressed. Also think about like whether or not it's appropriate to touch somebody, if it's appropriate to touch the opposite gender of yours, how close you're able to be or not be, how eye contact should be. So there's lots to consider in this particular table. And then you also want to make sure that your information is clear and easy to read. So when you're in, like if you're writing something in Word, and you look at the word count in there, you can also get information on the grade level of the materials that you're developing. So I encourage you to make sure that that whatever it is that you're writing, that it's at a grade level that's appropriate for your audience. A lot of people recommend writing at a 6th grade level. I have a number of folks in the division that I work with who have 5th graders, and sometimes like I'll send stuff home and just say, can you have your kid read this and tell me what they think it means, so that way we can make sure that we're on topic. Make sure that you have fonts that are 12 or bigger. Use images that are culturally relevant. Use bullets and white space to kind of break things up. Make sure also that you have nice pictures to go with things. Okay, and then you want to also make sure that your materials are usable. So not your materials, but your presentation. Make sure that you're interacting with your audience in a meaningful way. So ask open-ended questions. If you need to use an interpreter, use somebody who's medically trained, and know the difference between a translator and an interpreter. So an interpreter is required to say things verbatim. So if some of you, I think some of you currently work in clinical settings, so you would want to use an interpreter, not just a translator. Check back for understanding to make sure that they're getting what you're saying. So ask for feedback. Ask them to tell them what you said. And if you're working with a translator, have that information through the translator get back to you, or the interpreter rather. And then make sure that you get trained in these. So there's all kinds of ongoing trainings on health literacy, using plain language. The Centers for Disease Control has great information on their website, and I encourage you to take a look. So in terms of cultural competency, there can be a whole college course just designed on cultural competency. And so not everybody's treated equally in the healthcare system, and so that's why there's been more and more of an emphasis over the years to focus on cultural competency, because we want to make sure, again, that we stay relevant. I know I say that a lot, but the truth be told, if you can't get your message across to people, then it can be the most important message ever, but it dies with you. So you have to make sure that you're conveying it in a way that is going to stick with folks. And cultural competency is intended to optimize the likelihood that individuals from all cultures, ethnicities, and races will be able to receive appropriate and sensitive care. So some standards. In an effort to promote cultural and linguistic competency, some standards have been developed around three key themes. One is to develop culturally competent care, increasing linguistic accessibility, and then also using organizational supports. So in terms of developing culturally competent care, it's care that's respectful and compatible with the client's cultural practices and beliefs, as well as their preferred language. So having a diverse staff can really help with that. In Orange County, we're required to provide materials and services in the threshold languages, which are English, Spanish, Vietnamese, Korean, and Farsi currently. And then we also want to make sure that we're providing training in terms of cultural and linguistic competence to provide the best care possible. Another theme is linguistic services. So if there's not somebody who's bilingual, then to make sure that there's interpreter services that are available. It is a public health standard. We just recently got accredited as a health department, and we had to prove that we were able to do this. And we actually have interpreters that we contract with to make sure that we've got the most professional services possible. And making sure that we're providing language assistance to anyone who might need. Also making sure that our signage is in the languages that people need in order to be able to have a successful visit. And then using organizational support. So this really has to do with policies, providing training of staff, and making sure that there's ongoing efforts around cultural competency. I think for me personally, I don't think that cultural competency is a one and done kind of training. It's something that we want to understand more and more. And cultural competency really goes beyond just understanding kind of like the food and the festivities of people. It's really understanding values and for me, like understanding why people may have immigrated to the United States and kind of what were the political aspects of that. And then to also think about the demographic information of the people who you're serving, so that way you can think about what kinds of cultural practices may be important. And then having community partners, so that way there's genuine community involvement. We do have procedures in place in case of a grievance. If somebody feels like they weren't treated fairly, we want to make sure that we do right by folks and have processes in place. And then also making sure that any kind of public information, so media campaigns, posters, press releases, formal announcements, are stated in a culturally competent as well as a linguistically competent way. And so what I mean by that is that we're not just trying to translate something, but we want to make sure that that it's contextually appropriate. So like, for example, we've had a couple of quick things. One is a nutrition class that one of my folks was going to teach in Vietnamese. And so they translated the recipes and they translated the lesson. But she came out to me and she's like, Amy, we don't eat this food. Like, I can talk about this, but this isn't like, nobody in my audience is going to sit down and eat this. So we needed to change things up. So it's not just linguistically correct, but linguistically relevant and appropriate. Also, translation sometimes can get funky. Again, in Vietnamese, there was a piece on our website on breastfeeding, and literally translated, instead of saying breastfeed, it translates to give a breast. So not quite right? So you want to not only translate, but again, kind of goofy check it and make sure it's correct. So the Tuskegee syphilis experiment was really, a horrible thing that happened in our history. And it really created, unfortunately, a lot of mistrust. And so it happened in the 30s, and actually beginning, in the late 20s. Public Health was completing a study on the prevalence of syphilis amongst African American men in Mississippi, and So individuals with syphilis were left untreated, and also they did not provide any education. And nobody referred to syphilis by name. It was only referred to by as bad blood. And so in the rural South, that could include many health conditions at that time. And so the thing with syphilis is like it can be sexually transmitted. In fact, it is sexually transmitted. And it also can be transmitted perinatally, so it can be passed from mom to baby. It can result in blindness. It can result in cognitive disorders. So, it's a really, it's a very threatening disease. And so here folks were given this disease and they weren't given any information or any treatment about it and were just treated as an experiment. And so with Tuskegee, I mean, that leaves people with, I think sometimes a lot of fears, a lot of angst. I think I've shared at some point, I've done prison outreach, and the women in the prison, I was working with women living with HIV, and they would bring up Tuskegee. Like, that still leaves bad feelings with people because of the distrust. So in terms of strategies for working in diverse cultures, you want to work on strengthening the individual, strengthening the community, and reducing the barriers. And for health educators ourselves, it's nice to have a diverse team of health educators, so that way we can reflect the community. But none of us are going to be all things to all people. So regardless of who we are, we have to come with some cultural competency and awareness, and be aware of the history of abuse that has occurred in some minority populations, and that can lead to mistrust. So it takes some time, but you can cultivate trust with people. Just, I think, coming in with respect and sometimes even acknowledging past hurts can help to build trust. It does help sometimes that the presenter, the health educator, can be of the same culture. But again, if a person can't be, just having that willingness to understand and to listen, to let people talk about past hurts is all okay. So to plan, get some information in advance about your audience and their background, and consider the demographics of them. Think about their language proficiency and also your language proficiency, and get a translator if you need to. Look at what their current health status is and kind of what the trends have been. Talk to people who are from the culture or from the community, and then adopt your teaching strategies appropriately. There can be also overlaying cultures as well, such as the culture of the church or the culture of a school or other kinds of institutions. So it's not just culture related to race and ethnicity, it's also culture related to gender, sexual orientation. There's a number of other things to consider. So in summary, we definitely want to have a good working knowledge as health educators of non-majority populations. And just remember that not everybody from minority populations are the same to one another. So understanding all of those nuances and not making assumptions is very important. Make sure that we're optimizing our health education strategies and materials. And then also making sure that we're optimizing the opportunities for service and treatment to provide those in our care with the best care possible. And then remember history, so that way you're mindful of apprehensiveness that some people might have with your health education interventions. And with that in mind, I'm sure you're going to be a great success. Thank you.